and the students, of course, will keep WHO classification live questions. So I'll begin with introduction slides before we go to cases per se. So this is a current WHO classification of mature B cell neoplasm. And we can see there's a list of neoplasms that are there. This continues in the next slide and in the next. So now, according to ontogeny of B cell lymphoma, the lymphomas are derived from germinal center include Hodgkin's lymphoma, DLBCL, both activated B cell type, and the GCB, germinal center B cell type, double hit lymphoma, Burkitt's lymphoma. The ones which arise from mantle zone are mantle cell lymphoma, and the one arising from marginal zone are marginal zone lymphoma. From peripheral area arises CLL, LPL, and plasma cell neoplasm. This is the current classification of mature T and NK cell neoplasm. So we went through this extensive list, but what are the common lymphomas amongst adults and children? So Manvi, what are the common lymphoma you know of among adults?
I mean, adults, CLL,
Okay,
mantle cell lymphomas.
okay. Commonest lymphoma.
Commonest
Anyone else? Like Isha?
lymphoma, Hodgkin's.
Hodgkin's, correct. Then
And
anything else?
DLBCL.
DL, very good. So DLBCL and DLBCL and Hodgkin's, as correctly said, are common amongst adults. So now, Sayan, would you like to say which lymphomas are common amongst children?
Mantle zone lymphoma.
Children.
Burkitt's lymphoma.
It's Ltisha. Ikra?
Ma'am, Burkitt's cell lymphoma.
Anything else?
Ma'am, mental.
Naveen? Okay. So apart from Burkitt's lymphoma, Hodgkin's lymphoma, T lymphoblastic lymphoma, and ALCL are also common amongst children. Okay, so it is important to know what are common among which age group, because you should not blindly see things like you have to look at history, what is common, and then go about it. So you should be knowing what are common lymphomas among these age group. Okay, so diagnosis of lymphomas is multiparametric. It depends on clinical presentation, imaging investigation, and multitude of lab investigations, which include morphology, immunohistochemistry, immunophenotyping, FISH, and molecular genetics testing. So today's topic is flow cytometry and CLPD. So I'm not going into details of flow cytometry, but just basic, what does flow cytometry mean? So the word flow is flow in a stream. Cyto is cells, single cell suspension, metry is measurement. So measurement of cells in single cell suspension is what flow cytometry means. So unlike what you see in morphology or lymph node biopsies, you see architecture. Are there nodules? No nodules. In flow cytometry, you are not seeing any architecture, but you are doing pattern-based analysis. You are looking at single cell at n number of antibody. Like if you add 6 colors, you can see those 6 antibodies are present or not in that single cell. And according to the number of antibodies in that single cell, you can see that which antibodies are present. Then it is rapid and independent analysis of large number of cells. Okay, so unlike morphology, you can look at patterns. So now in this slide, I would like to show you that this is actually a B cell maturation slide. Okay, this is these are hematogons 1, which are in orange color, hematogon 2 are in green color, and mature B cell are in blue color. And when we look at their pattern in different antibody combination, we can look at how they're maturing. As the cells mature from hematogon 1 to 2 to 3 stage, they gradually acquire both CD20 and CD45. So they are following this pattern that is there. Similarly, when when we see in 10 versus 45, we can see that they are losing their CD10 and acquiring more CD45. So we can see a pattern, the way how cells follow in. And this article by Dr. Fiona Craig is a must-read article for all postgraduate, because it explains very well how flow is used in hematological malignancy. Now, when we analyze in flow, it is important to know what cells fall in which area. So now these cells which are in dark blue are CD45 expression. Yeah, sorry. Manvi was saying something. What CD45?
CD5 expressed as positive here.
Yes, positive.
Common leukocyte antigen.
Yeah. So we kind of say that instead of positive, negative, how do you like to say that? What kind of expression they have? 45.
Bright.
Yeah. So bright. 45 bright. So this blue and lighter blue both have 45 bright, but they have difference in their side scatter. These are what side scatter?
Smaller than.
Yes. So low side scatter. So small cells, 45 bright, low side scatter. What cells are these?
Small lymphocytes.
Yes. So these are lymphocytes. And what are these light blue cells?
They are larger.
Monocytes.
Monocytes.
Perfect. And what are these cells that are here? How do you define the CD45?
Positive.
Perfect. Yeah. So these are CD45 dim expression with low side scatter similar to lymphocytes. So what is this area called? This area is called progenitor area. Progenitor cells, basophils, these fall in PDC, they fall in this area. Now, what is this? What are these cells? 45 is how in this?
Very dim.
It is negative. It is like, if you see 0 is here and it is falling in this level only. So it is 45 negative and low side scatter. What could these cells be?
Nucleated RBCs.
Very good, nucleated RBC. And what are these cells in green?
Granulocytes.
Why do we say these are granulocytes?
They have both high side scatter and high forward scatter.
and CD45 positive.
Yeah, so 45 is dimmer as compared to lymphocytes and monocytes, and they have higher side scatter. So these are granulocytes. Now, when we reverse the x-axis, and in on the right side, this plot is when we have reversed the axis, 45 is in x-axis, side scatter is in y-axis, same cells. But in this, we have not used logarithmic scale, we have used linear scale. So in this, again, low side scatter, 45 dead negative, we have NRBCs, and we have this area of progen where 45 dim and low side scatter cells fall. 45 bright, low side scatter lymphocytes here, 45 bright, higher side scatter monocytes, and very high side scatter and dimmer 45 in grams. So this is how it appears in 45 in linear, 45 in log scale and side scatter in linear scale, with 45 being in x-axis. Okay, so this is a basic thing. So now when we talk about flow cytometry in CLPD, flow cytometry plays an important role in diagnosis, subtyping, as well as prognosticating chronic lymphoproliferative disorder. And the patients usually present with lymphadenopathy, so they go ahead and get biopsy done, and in biopsy a report comes, and then patients come for bone marrow aspirate when they come to us. However, sometimes we also receive bone marrow sample or peripheral blood sample or FNA sample where diagnosis of non-lymphoma has not yet been established. For such cases, what should we do? For such cases, we should put a screening tube. Okay, screening tube where we use wide range of antibodies to narrow down which kind of lymphoma it would be, so that accordingly we can put further panel. So in our lab, this is a brilliant tube that we use, and like I'm a fan of Prashant sir for designing this tube. And in this, this is a 13 color panel. However, we have 16 antibodies, and among these 16 antibodies, actually, a few antibodies are mutually exclusive of each other. And this screening tubes help us to screen for BCLPD, TCLPD, and acute leukemias as well. So if we see how this tube has been designed, here antibodies are used in such a manner that CD4 and 20 are used together. So 4 will stain T cell and 20 will stain B cell. So these are mutually exclusive of each other. So in the same fluorochrome, such mutually exclusive antibodies are screened, and such screening tube has been designed for screening such lymphomas which have not yet been diagnosed. So if we see how do we diagnose B-cell lymphomas, neoplastic B-cell are different from normal B-cell in immunophenotypic feature by either light chain restriction and aberrant B-cell antigen expression. So just light chain restriction will not help us in diagnosis. So we have to look at both these parameters. So what do we mean by light chain restriction? Okay. So does anyone want to define what does light chain restriction mean? So Ikra?
Yes, ma'am.
Yes. If I say something is kappa restricted, what does it mean? Cells are kappa restricted.
They're expressing kappa immunoglobulin.
Right. So this, but they are not expressing lambda immunoglobulin. So basically, clonality in flow by light chain restriction is by seeing what these cells are expressing. So usually, B cell express both kappa and lambda. Like a subset of B cell will be expressing kappa, a subset will be expressing lambda. So if you look on the left side panel, you can see that these cells which are in maroon are expressing kappa, while the cells which are in green are expressing lambda. These cells never express both the antibodies. They'll be either expressing kappa and lambda, and when both kappa and lambda are expressed, that means these are polyclonal kind of B cell. But when there is light chain restriction, that means only one antibody is being expressed. So on the right side, we can see lambda restricted B cell, which are expressing only lambda and not kappa. Okay. Now, then if you go to mature T cell and NK cell neoplasm, T cell and NK cell neoplasm account for 10 to 15% of all NHL. They are rarer as compared to BNHL. Okay, and when we look at T cell, neoplastic T cell, they have aberrancy with loss of one or more pan T cell markers. So you need to use all the markers CD3, 4, 8, 7, 5, 2, and loss of expression of either 3, 2, 7, 5. Any of these can happen in these neoplastic T cells. However, not all CD7 negative T cells are abnormal. This is important to know that normally also we have a small subset of CD7 negative T cell which are found in skin and blood. Similarly, T cell, TCR gamma delta cells, they lack expression of CD5, 4, and 8 and should not be interpreted as abnormal. So, to interpret anything as abnormal, you should be very confident about how the normal pattern is. Okay, so one need to familiarize with normal antigenic variation among normal subset of T cell in order to identify abnormal T cells. altered intensity of staining. Okay, like normally how much CD3 they should be expressing. If they're expressing a dimmer CD3 or brighter CD3, this also may be indication of neoplastic cells. And normally in peripheral blood we have CD4, which is more as compared to CD8 positive T cells, while in bone marrow CD4 and 8 ratio is almost equal, or maybe sometimes CD8 is slightly higher than CD4 positive T cells. Alteration in CD4 and 8 ratio may occur in neoplastic T cell. However, you should remember that it may occur in other conditions which include HIV, and it is not a surrogate marker for neoplasia. So it is important to know that you have to take multifactorial consideration for diagnosis of lymphoma, from evaluating in clinical history, the imaging findings to immunophenotyping findings and biopsy findings. Everything has to be taken in integration. Okay. Now, if we look at the approach to T cell lymphoma, I'll be discussing B cell lymphoma with the cases, but I had not given any T cell lymphoma cases. So here I'm discussing the approach to T cell lymphoma. So as I said that what markers we should be putting, we should be putting initially for screening CD2, 3, 4, 8, 5, 7, 16, 56, TCR gamma delta 45. And the tumor cells may be surface CD3 positive or negative. The ones which are surface CD3 positive, if there's TCR gamma delta negative, the surface CD3 positive also should have normal surface CD3 positive cells have TCR gamma delta positivity. However, if you establish flow cytometry based T cell clonality either by V beta repertoire analysis or TRBC1 analysis, you may show that these are clonal kind of T cells. Now, aberrant under or overexpression of any of the markers may indicate malignancy, but we have to further analyze these cells with various markers. Now, what are the CD4 positive 8 negative lymphomas and 4 positive 8 positive dual positive lymphoma? They include angioimmunoblastic T cell lymphoma or also follicular helper T cell lymphoma. For diagnosing these, we need 2 or more of these markers, which include CD10, CD185, CD278, CD279. And for adult T cell lymphoma leukemia, we need CD25 positivity, CD26 negativity, and HTLV1 positivity. While for anaplastic large cell lymphoma, large cells with higher forward scatter, CD30 positive, 25 positive, 26 positive, ALK may or may not be positive depending on ALK positivity of the subtype it is. And TPLLs are usually have high TLC, have pro-lymphocytic morphology, and are CD7 positive, 30 negative, TCL1 positive. While the cutaneous T cell lymphoma or mycosis fungoides are CD30 positive or negative, or CD25 positive or negative. They have characteristic irregular nuclei with cleaving and cutaneous lesion in them. And similarly, the 4 negative and 8 positive lymphoma, and dual negative 4-8 negative lymphoma include LGL leukemia lymphoma, enteropathy associated T cell lymphoma, subcutaneous panniculitis like T cell lymphoma, hepatosplenic gamma delta T cell lymphoma, and cutaneous T cell gamma delta cutaneous T cell lymphoma. And if we know that these are clonal, however, are not meeting the criteria for above neoplasm, the diagnosis of exclusion for such lymphoma is PTCL NOS. So here I have demonstrated an example of T cell clonality using TRBC1 antibody, just like kappa and lambda. The polyclonal T cell will be TRBC1 or TRBC2 positive. So we can use TRBC1 antibody, and we can see that they'll be either a group will be positive for TRBC1 and a group will be negative. So in the above panel, we have polyclonal T cell where we can see that CD3 positive, CD4 positive, CD8 positive. Here, everywhere we are seeing a polyclonal kind of distribution. However, in the lower panel, we have a CD4-8 dual positive population, which is expressing TRBC1. However, there is no population that is there in TRBC1 negative area. So this is clonality that is demonstrated by flow using TRBC1 antibody. So what are advantages of flow cytometry? It is very sensitive as compared to IHC. It can identify a very small population of tumor cell confidently. It is multicolor, unlike IHC where, in one section you put 1 or maximum 2 antibodies. Here we are using, depending on number of fluorochromes we are using, we can use multiple antibodies in the same tube. We can identify patterns. I had shown you B cell maturation where we could identify clear patterns by flow, and I showed you example of clonality by both for B cell as well as T cell, where we can identify clonality on flow cytometry. So with this, we go to case 1. Do we have any questions till now? Sorry.
Yes, ma'am. We do have 2 questions. First one is from Jitendra Sinha. He asks how ideally one should collect a flow sample.
Okay. So collect flow sample for like EDTA sample or heparin sample, both are acceptable for flow cytometry. However, if you are talking about FNAC or if you are talking about CSF, these have different methods of collection. So for peripheral blood and bone marrow, you can take an EDTA sample and transport it at room temperature to the lab. And EDTA or heparin, both samples can be used for flow cytometry. While if you are taking CSF or you are taking any fluids, the cells degenerate very quick. So you can use media We have RPMI media in which a sample can be transported, in which cells will be preserved. While FNA sample also we can take in media so that we can use it, and you can use it for sample processing for a longer period of time.
Another question is also by him regarding the time limit for processing a fluid for flow cytometry.
Time limit for processing now, depending on if you are processing it for flow cytometry, a fluid sample, and if you have not used any media. So ideally you should be doing it as soon as possible, within 2 hours, I would say. But if you have used media, then you can keep it overnight also and use it for 72 hours also.
Thank you, ma'am.
So,
No further questions.
right. We go to case 1. So case 1, Naveen, can you read the history, please? Naveen, are you there? Ikra?
Yes, ma'am.
Now, ma'am?
Please go ahead, read
Naveen.
history. Naveen, yeah, please go ahead. Naveen.
Yes, ma'am. So the clinical history is a 61-year-old female who came with the complaints of fever on and off for past 4 months, weight loss of 5 kilograms of the recent 2 months. On examination, there was no lymphadenopathy, but splenomegaly was present. So CBC was given, and the hemoglobin is 7.9, which is normal. TLC is 74,000. Platelet count is 1.76 lakhs. The absolute neutrophil count is 2,000, and the absolute leukocyte count is 63,000.
So what do we see in this smear now?
In the peripheral, yes, ma'am.
Yes, what do we see now in the smear?
Yes, ma'am. Coming to the RBC morphology, we see a normocytic normochromic
If you look at
RBCs.
the smear, what is the most striking thing that you see? Do you see any abnormality in RBCs or WBCs?
WBC,
Yeah. So whenever you have a case, try to describe the finding that is prominent.
abnormal cause.
Yes, yes, yes.
So there is increased total count
Very good.
with increased lymphocytes,
Right.
lymphocytic predominance, and there are smudge cells seen.
Smudge cell seen. Okay. So and so you correctly said smudge cells are seen. Anything in the nuclei that you see characteristically? So Ikra, do you want to answer this?
Yes, ma'am. Prominent nucleoli are seen.
Prominent nuclei are seen. So you see prominent nuclei here, you mean?
Yes.
Yes, ma'am.
Is this a preserved cell? Do you see any prominent nuclei in this cell?
No.
You see a prominent nuclei in this cell. So you are talking about these, which
The lab cells have
Yeah.
prominent.
So do you think these are preserved? Do you see any cytoplasmic border? Like here in this cell, you can see a proper
There is thin
cytoplasmic
amount of cytoplasm.
Yes, ma'am.
border. Are these cells preserved cells? Do you think
Might be.
these are
They're
actually
probably
sweet cells?
smudged.
Yeah. So we don't see any prominent nuclei per se. What kind of chromatin these cells have?
So,
Yeah, of course.
dense to light chromatin, appearing like a soccer ball.
Yeah,
Soccer
soccer ball chromatin kind. So so here we are seeing soccer ball like chromatin, which is characteristically seen in which kind of. So here, what does soccer ball mean? So we have this dense area where the chromatin is very dense, while this lighter area where the chromatin is lighter. Okay, so that is why it is giving you kind of a football kind of appearance, right? So crack mud or soccer ball pattern we call it, and this is characteristically seen in which malignancy, Kritika?
CLL.
CLL, perfect. So now we go to flow cytometry. So Sayan, would you like to tell what do we see? In which area are we seeing prominence?
And we are seeing the prominence in the lymphocytic area of the graph,
Yes. So
showing
we
low
see-
side scatter and CD45 highly positive.
Yes. So 45 bright, low side scatter cell, we are seeing 91% cells there. What are these cells expressing? How is the CD19 expression in these cells?
CD19 expression is quite high, and
Okay,
CD20 expression is
When
going
we
from low to high.
quantify these expression, we call it moderate, dim, or negative, bright, that way. So we don't call it high or that way. The scientific way of describing is moderate, dim, negative, or bright. So how do we say if it is moderate or dim or negative? It is depending on comparison with their normal counterparts. Okay. So here 19 expression is moderate for this. And what kind of 20 expression is there, Isha?
Ma'am, moderate.
Moderate. So CD20 expression, if you see in these cells, it is going up to 0 also. Do you still want to call it moderate? It is going from moderate and it is going to negative level also. So it is kind of variable expression. Yes, variable expression. Now, what kind of CD5 and CD200 expression are these cells showing? Manvi,
I can't see.
you can't see.
Screen is there only.
One second. For you, screen is there only. You can mobilize the screen. Like you can click on the screen and then shift it left or lower somewhere. Okay, Isha, can you see what kind of CD5 and 200 expression is it?
Ma'am, CD5 moderate and CD200 is variable, I'd say.
Okay, so now CD5, why do we say moderate? What are these cells that are there? These cells in brown? T lymphocytes. So these cells are reaching up to the level of T lymphocytes. So we are calling them moderate. Fine. CD200, we have nothing to compare. So I would say that this is moderate only. That's okay. Now, what else? Now, CD23. How? What kind of expression is it?
Variable
Variable. Very good. Very good. And are these CD10 positive?
negative.
CD10 negative. And in light chain, are these light chain restricted?
Restrictions there.
Perfect. And what about CD49D? Do we see cells in CD49D?
Oh,
Almost no. Yeah, very few
very
dots. Yes, yes. So we have B cells that show, so we have 19 positive, 45 bright, yes, 5 positive tumors. So in morphology, we were thinking of chronic lymphocytic leukemia, and flow also, with all the expression pattern, we have a diagnosis of chronic lymphocytic leukemia because we have CD200, 23 may or may not be there sometimes, but with the classical morphology and presence of CD5, 200, we can diagnose comfortably this as chronic lymphocytic leukemia. Okay. Now, what about other neoplasm that is CD5 positive? CLL is CD5 positive, 200 positive. If it is CD5 positive and 200 negative, which lymphoma this would be? Or what are the lymphoma which are CD5 positive but 200 negative?
Mantle
Mantle zone hairy cell leukemia.
So hairy cell leukemia, is it CD5 positive?
Oh,
So I was talking about CD5 positive but 200 negative. So usually it is mantle cell lymphoma. Mantle cell lymphoma also express another marker that is CD148. They have good CD148 expression, and they unlike CLL where we see dimmer CD20, these have CD20 moderate expression, mantle cell lymphoma. Okay. Now, yeah. So I had asked a question: what is the importance of CD49D in CLL in this case that we have used? So Sayan, would you like to answer this?
CD49D is a marker for the homing of the lymphocytes.
Okay.
So they have some implication in progression-free survival. in some
Progression-free
cases.
survival. So they have importance in prognosis. The patients who express CD49D are associated with poorer prognosis and poor survival. That is why it helps us in prognosticating patients of CLL. Okay. Now, I had given this plot, just fish for P53. Kshitija, would you like to interpret? What do you see in this? What do you see in this cell? Green signal is for what?
Green is for
CEP, right? And red signal is for T53. How many green signals and how many red signal are we seeing in this cell?
1 red, 2 green. 1 red and 2 green is there.
Yes. So what does it indicate?
Deletion of T53 is positive.
Yes, this patient is positive for T53 deletion. Now, we also gave another NGS plot. So this is integrated genome viewer where there is presence of a T53, a small deletion that is there of 2 base pair. And now the variant allele frequency was 93%. You know why this happened? You have in one of the allele, you have complete deletion of T53. And in another allele, you are having a small portion of mutation that is there in T53. Because of that, the variant allele frequency of T53 mutation has increased. So among the mutations that are commonly seen in CLL include Notch1, ATM, SF3B1, TP53, and BID3. Now, among the TP53 disruption, 60% of patients carry both deletion as well as TP53 mutation, as was seen in this case. I had also given a plot of IGVH mutation analysis. So what we usually do is for a normal, for this sequencing, what is done is primers are used of leader region as well as framework region, depending on what works for what case. And this IGVH sequencing is done, So what happens is in normal person, the immunoglobulin variable region. So this is a variable region. For once antigen exposure happens, like suppose I get a fever, I get a viral exposure, or so an antigenic exposure happens, and after the antigenic exposure, antibody is formed. So for that antibody to form, there is a mutation that happens. And so among polyclonal B cell, you will see various kind of IGVH rearrangement. However, when you have a clonal kind of cell, you will see one kind of IGVH, that is clonal IGVH. So what we do is we sequence them, and first of all, we look at what kind of IGVH sequence we have detected. Okay, so in this case, we had detected IGHV439 sequence, and this had identity of 99.45% to the germline. So why do we need to identify these if it is close to the germline or not? Depending on if it is close to germline or not, it is identified as mutated or unmutated. The mutated ones have more than 2% mutation compared to germline, and these are associated with favorable prognosis, while the unmutated have more than 98% homology with the germline sequence and are associated with unfavorable prognosis. Okay, this also has been included in CLL IPI scoring, where in the international prognostic scoring, your unmutated IGVH also carries 2 points. So that is why it is important to identify this. Okay, so with this, do we have any questions for case 1? Manvi, Isha, Sayan, Kshitija, Ikra, Naveen first.
Ma'am.
Yes.
We have one question in the chat box.
Yes. Yes.
Sanjeev asks why the nucleoli are prominent in the poorly preserved cells.
So we should not be interpreting poorly preserved cells because they are getting smudged. So nucleoli, commenting on nucleoli should be only in preserved cells. Why it should it's like on dead cell you cannot be commenting anything. You cannot be commenting their size. You cannot be commenting their shape. You can't be commenting anything. So you should not comment on nucleoli on these smudged cells. So I had seen another question. Is 49D a part of CLL IPI? No, it is not a part of CLL IPI, but it is a prognostic marker. So is there any other question, Dikshana?
Ma'am, Pallavi asks, can these prominent nucleoli cells resemble prolymphocytes?
For if they were pro-lymphocytes, they should have been preserved cells. So you can't be, you have to have preserved cells with prominent nucleoli for calling them pro-lymphocytes.
There's another question. Hind asks how to decide the gate position in the kappa lambda plot.
That is a very good question, and we practically face many times this, how to decide gate position. So how we usually do is by using with normal B cells, like the normal B cells we use to show kappa lambda plot. So I'll just go back to the plot. Yeah. So what we usually kappa or lambda, they fall on either side. So in the middle, whatever comes is non-specific binding or so we should not interpret at this area. They should either be kappa restricted or lambda restricted. So what you can use is normal B cells either in the same patient or in a different patient or normal sample that has been run. And in this area, we can use a hinge kind of plot where I'll just use what we do is we use hinge kind of plot where we draw like this and draw a central hinge, like a bifurcated kind of plot to discriminate between kappa and lambda, and we use normal B cells either in the same patient or different patient to determine the cutoff for determining kappa.
Thank you, ma'am.
Yeah. So we'll
No
get to
further
the
questions.
case 2. So can Kshitija read the history, please? Kshitija, are you there? Is it Kritika or Kshitija? I think I've written it wrong. Kritika.
Kritika.
Sorry,
Kritika, ma'am.
Kritika. Kritika, can you read the history, please?
The patient is a 5-year-old male child who has come with complaints of abdominal discomfort for a month and mass in the jejunum. On CBC, we see that hemoglobin is 10.7, which is low, and total leukocyte count is 6,000, and platelet count is 1 lakh.
With this clinical history, what lymphoma strikes your brain?
Ma'am, because it's a child, and it can be an extranodal, not extranodal, but even Burkitt can present with a mass, abdominal mass. So
Okay.
first thing is that.
Right. So
And other maltomas can be there, which can present, and sometimes mantle cell lymphoma is also present with polyps in the abdomen, like GI.
okay. So now, with considering the age, which lymphoma would you think first?
Burkitt's first, because it's a 5-year-old child.
Perfect, perfect. So what do you see in morphology, Sayan?
And we have a bone marrow aspirates here, which is highly cellular, and it is showing clusters of cells. The cells are having an open chromatin pattern. Few cells have a prominent nucleoli, irregular nuclear membrane, and particularly they all have cytoplasmic vacuolations.
Okay. Okay. So with this morphology, if you do not have any clinical history, and if you look at these cells, what would you call them?
I will tend to call it a Burkitt lymphoma.
Like, would you be very sure that these are Burkitt lymphoma cells only?
BL3.
Okay. Ikra? Manvi, what do you have any different opinion?
And Burkitt's blast and cells are same. So
Okay, so just based on morphology, if you don't have any flow cytometry this thing facility, what would you sign it out as?
Can also be AL3, ALL3 kind.
Okay, okay. So how would you sign out in this case, such cases?
Acute leukemia, like they're given the counts in the picture.
So it is best to sign out as bone marrow is involved by inactive lymphoid malignancy, and possibility of Burkitt's versus acute leukemia also should be kept, but you cannot just based on morphology sign it out as Burkitt's only. Okay, it's important. You should always advise for flow cytometry in such cases. It becomes very important for diagnosing in such cases. So Manvi, would you like to describe the flow findings? What do you see?
ma'am,
which cells are prominent in the first plot, in the 45 versus side scatter plot? What
Red
which
cell population. Red cell population.
So which region are they? Are
And
they
they're
blast region? Are they lymphocyte region?
lymphocyte,
Monocyte?
lymphocyte, ma'am.
Yeah. So there is lymphocytosis in morphology. So if these were blasts, if this was acute leukemia cases, where would the cells be?
Come towards
They would fall under mostly in this region.
someone down and
45 dimmer progeneration.
yes, ma'am.
Now, Isha, what is the expression of CD20 and 19 in this case?
Ma'am, CD20 will be moderate and CD19 will be moderate only, both moderate.
So you call it moderate, bright, both is fine. Okay. Sayan, what does this indicate in the 19 versus forward scatter? What does these cell indicate?
19 indicates moderate intensity, and forward scatter is variable.
Yes. So what does it mean that like forward scatter coming towards a higher side also? What does it mean?
Cell size.
And the cells have increased in size.
Right, perfect. So larger cells have higher forward scatter. So these we are having large cells in flow also in this case. Okay. Now, Ikra,
Yes, ma'am.
3810 expression.
Ma'am, the 38 is moderate and CD10 is brightly positive.
Okay. IgM expression, IgM, IgD.
Ma'am, in IgM, BV605 is brightly positive, whereas IgD, BV is moderate.
IgD is also moderate.
Oh,
Yes, ma'am, moderate. No,
How do
ma'am, it is brightly positive.
IgD.
dim, I think so.
Dim expression.
It is very dim.
Actually, it is negative. IgD is negative, IgM is moderate. Okay.
Moderate.
Among light chain, is it any light chain restricted?
Lambda.
Lambda.
Is lambda restricted. So, and this also showed expression of BCL6
BCL
CD19.
negative for BCL2. So now this case we had 19 positive, 5 was negative, 45 bright. CD10 was positive in this case. CD38 was also bright. 81 I did not show you, but BCL2 was negative. So this case fits with diagnosis of Burkitt lymphoma. What are other lymphomas that are CD10 positive?
TLBCL.
DLBCL. Any other lymphoma?
Follicular lymphoma.
Right. So follicular lymphoma would be CD10 positive. However, they usually have lower forward scatter and CD38 is dim or negative. Okay. While the cells which are CD10 positive with higher forward scatter are large B cell lymphoma. DLBCL now is labeled as large B cell lymphoma. And CD10 negative lymphomas with higher forward scatter are usually large B cell lymphoma only. Now we'll go to fish finding. So Kshitija, what do you see in fish?
Ma'am,
Kritika.
ma'am, in fish there is like because red, so red shows MYC and green is for IGH. There is fusion of IGH and MYC genes.
Right. So translocation 814 is present because this is dual fusion, dual color, dual fusion kind of probe, where if you see separate green signal and red signal, that is normal. While once fusion happens between these genes, you will see additionally yellow signal. So you can see a IGH MYC 2 yellow signal and 2 separate red and green signal. So this green is the signal from normal IGH, and this red is signal from normal MYC. While these two fusion signal are from IGH MYC and reciprocal translocation of IGH MYC, both. So 2 fusion signal and 1 red, 1 green signal we see, which indicates fusion of IGH with MYC. And this is classically seen in Burkitt's lymphoma. So Burkitt's lymphoma, it is a neoplasm usually seen in children. And now in current WHO, they have been subtyped as EBV associated and EBV negative, and they have excellent prognosis with chemoimmunotherapy. Any questions on case 2?
When the translocation in the fish,
Yes.
the interpretation of translocation is a bit like how to interpret the translocation.
Okay. So what happens is normally they the IGH and MYC are apart. We are using probe that will go and bind to IGH and MYC. Okay. So they are apart. One is in chromosome 8, another one is chromosome 14. Right. So what happens is once translocation happens, a part of 8 comes to 14 and another part of 14 goes to 8. So there is translocation and reciprocal translocation. Okay. So now what happens is when you are using a red probe and when you're using a red and a green probe. So
Dr. Shweta,
yeah.
can I please request you to put the
I'm
battery
already-
on?
Yes. I had already put it. I think it was loose. I just 1 second. Now is it okay, right?
Yes, ma'am. Thank you.
I think that was loose. I didn't realize it. Okay. So now what happens is you see normally you see a green signal, 2 green signal and 2 red signal, because from each chromosome you are getting 2 signals. However, when translocation has happened, there'll be fusion. So both the signals will come together. both in translocation area and reciprocal translocation area. So you will get two yellow signals, like you see red and green getting fused here, and you are getting in between yellow. Okay, again red and green getting fused here and getting yellow here. So two yellow signal and one separate red from normal chromosome and one separate green from normal chromosome. This is how it is interpreted. Okay.
Thank you, ma'am.
So we'll move on to case 3 now. Okay. Now, Isha, can you read the history, please?
Yes, ma'am. A 32-year-old male presented with fever, weight loss, decreased appetite, and generalized weakness from the last 20 days. On examination, the cervical lymphadenopathy was noted with largest cervical lymph node measuring 3 into 2 centimeters. On CBC, we saw hemoglobin, which was 4.2 grams per deciliter, TLC 36,000, and platelet count of 8 into 10 raised to power 9 per liters. So the hemoglobin is low, TLC count is raised, and the platelet counts are reduced, markedly reduced.
Right. So what do you see on morphology?
Ma'am, in this smear, there are lymphocytes, a lymphoid population, which is larger lymphoid cells, along with a few neutrophils are seen.
Right. In this area?
Ma'am, yes, in the nucleus of the lymphoid cells, these are intended.
Okay.
There is a cleaving in the cells.
Now, Sayan, Flo, how do you interpret this?
When the cells are showing variable in the red part, it's a moderate CD45 expression with high side scatter. And
High side scatter. How is the side scatter in these cells?
Low side scatter.
Low side scatter.
Oh, sorry.
Yeah. So in this area, we can see both red and brown cells. So what are red cells and what are brown cells? Okay. Kritika?
Both are like lymphocytic population because they have low side scatter.
Correct. But what kind of lymphocytes are red and what kind of lymphocytes are brown cells?
Some may be like larger than.
Okay. So brown cells in the right plot, the rightmost plot, the brown cells are positive for what?
CD5.
Good expression of CD5. The red are also positive for CD5, but dimmer than the brown cells. Okay. The red cells are also positive for CD19. So what kind of lymphocytes are these red ones?
B lymphocytes.
Correct. And what kind of lymphocytes would these brown cells be?
Probably T because
Perfect.
not expressed.
So in this 45 bright area, you will have both B and T lymphocytes. So here, the brown population are T lymphocytes, which are negative for 19, while are showing good 5 expression, and the red lymphocytes are B lymphocytes, which are showing good 19 expression, moderate 19 expression, and a little dimmer 5 expression as compared to the T lymphocytes. Okay, and how is CD23 in this?
CD23 negative, almost negative.
Yes, almost negative. Now, Ikra, are these red cells positive for CD10?
No, ma'am.
Very less.
Okay. What about 38 and 20?
20. Ma'am, for 38 they're negative, for 20 they are positive, moderately.
Okay. So this is a wrong labeling actually. This is a wrong labeling, but these are also showing CD38 expression and 20, yes, definitely they are positive. So what are these cells that are in purple here? 38 bright that are there. I mean,
But these don't show any bright.
sorry.
It looks like 38 negative.
No, no. Here in this area, purple small dots you can see. What are these
Plasma
cells?
cells.
38 positive plasma cells.
38 bright plasma cells. Okay. Now are these red cell kappa or lambda restricted?
Kappa
restricted.
Perfect. So and what about CD148? Are the red cells positive for CD148?
Yes, ma'am.
Yes.
Moderately positive.
Okay. So when I was explaining in the first case, CD5 positive, for 148 positive, what lymphoma was I telling?
Mantle cell.
Yes, perfect.
Mantle cell lymphoma.
Yeah. So when we look at the BCL2 expression, these are positive for BCL2 while negative for BCL6 and MUM1. So this is a case of mantle cell lymphoma where we saw a homogeneous expression of CD148. These were positive for CD5, however, negative for 200. I did not show this 200 plot, but this case was of mantle cell lymphoma. And in bone marrow biopsy, what kind of infiltrate do you see on morphology? Yeah,
Nodular aggregate.
nodular aggregate. And these are positive for what markers on IHC?
25.
What other antibody we can use in biopsy for this case? Isha? Have you heard of cyclin D1?
Cyclin D1.
All right. So cyclin D1 also can be used in these cases for mantle cell lymphoma. Okay. So this was a nodular infiltrate of mantle cell lymphoma in bone marrow biopsy. So
But cyclin D1 can be negative also.
yeah, but I just asked what another antibody you can use. I did not say that it has to be positive. I just said what other antibody you can use. Majorly they are positive, right?
But it was SOX11.
Yes, we can. Yes. So now, does anyone want to interpret this fish plot? Now, Naveen, would you like to interpret this? What do you see?
That is usually
There's fusion. Okay. So what does green color indicate?
IGH.
And red?
CCM.
Yeah. So cyclin D1, IGH fusion. So we are seeing two yellow signal, one red and one green signal indicating fusion of IGH and cyclin D1 in a case of mantle cell lymphoma. Okay. So with this, we come to an end of this case 3. We'll go to case 4 now. Do we have any questions before that? Prashant sir, do you want to add in anything? I actually have not asked you yet.
I request Dr. Prashant to please join in.
I think that is fine. Yeah. So we have done mental, CLL, and bucket.
Yes, sir.
So I think you're doing good. I don't see anything specifically to add.
So case 4, Manvi, can you read the history?
Yes, ma'am. 50-year-old male patient, abdominal swelling since 3 months and massive splenomegaly. Hemoglobin is 5.4 gram per DL. The leukocyte count is 2.8,000. Rated is 34,000.
Right.
It's a case of pancytopenia, ma'am.
Right. So, okay. So with this history, what do you think? Pancytopenia, patient with massive splenomegaly, what do you think?
Ma'am, something, marrow is not functioning properly. It is hypocellular or fatty. It's not,
Some bone marrow pathology.
bone marrow pathology is there, for sure.
So in such case, if spleen is massive, will you think of aplastic anemia in such patient?
Not if
Plastic
it's
is
massive. Splenomegaly, we will not
Plastic.
think of plastic.
So pancytopenia with splenomegaly with CLPD, will you think? Which
Hairy
cause?
Harry.
Very soon.
Hairy cell
Hairy cell
leukemia,
leukemia.
presents like this. What do you see on morphology in this case? Kritika?
Ma'am, so we are seeing like lymphoid cells that are showing a moderate amount of cytoplasm that shows characteristic cytoplasmic projections with round to oval nuclei that has condensed to opened up. It's not very opened up chromatin. So the
Are these
cytoplasmic
homogeneous
features
kind of chromatin, these cells showing?
Sorry, ma'am?
Are these showing homogeneous kind of chromatin? Like on the right,
is not
is this
homogeneous.
like, on the cell on the right that I'm showing with pointer, is this a normal lymphocyte or abnormal?
It is normal. It is a
Small
clump.
Small lymphocyte. As compared to this, these are larger.
Larger.
So it is little lacy kind, we would say.
Yes,
Yeah. And we have grayish kind of cytoplasm with fraying.
Fraying
that is-
cytoplasm. Yes, ma'am.
Yes. So this characteristic morphology we see in hairy cell
Hairy cell
leukemia.
leukemia.
Let's go to immunophenotyping findings. Manvi.
Yes, ma'am.
Yes, please describe the findings.
Ma'am, red cell population,
Mhm.
lymphocytes with moderate.
So among these lymphocytes, only red are lymphocytes or any other lymphocytes? we
No,
have?
ma'am, gray.
Yeah. So here we have given them brown color, but here gray color also lymphocytes, which would be T lymphocytes. But these are B lymphocytes, which are yes. So what kind of expression do they have of 19, 20?
Ma'am, 19, bright.
Very good, very good.
20, ma'am, bright or moderately bright.
Yes, perfect. Are they 5 or 10 positive?
No, ma'am.